Welcome everyone to the second of two online seminars that MDUK is holding this afternoon, as part of our Muscles Matter online seminar series, Living with a Muscle Wasting Condition in 2020 and Beyond. In this series of 12 seminars, we've been exploring what it's like to live with a muscle wasting condition in these unprecedented times. And in fact, this is the final one of these 12 seminars. 6 of them have been exploring specific conditions which have been aligned to awareness days, weeks and months that are taking place, and the remaining 6 have looked at a range of topics relevant to anyone living with muscle wasting conditions. The series has explored spinal muscular atrophy, Duchenne muscular dystrophy, mitochondrial disease, Becker muscular dystrophy, Charcot-Marie-Tooth disease, and living in a world with COVID, assistive and accessible technology, education, employment and financial assistance. And this evening, of course, we're exploring accessing services in the world of COVID and sort of looking to the future. If you want to look at any of the recordings of any of these previous sessions, you can see that in the slide that's presented at the moment. There's a link at the bottom of the screen. We're very grateful to PTC Therapeutics, our headline sponsor of the Muscles Matters 2020 series, for their generous support. PTC is a biopharmaceutical company focused on the discovery, development and commercialization of clinically differentiated medicines that provide benefits to patients with rare disorders, including Duchenne muscular dystrophy, and it was founded more than 20 years ago. PTC Therapeutics has successfully launched 2 rare disease products and has a global commercial footprint. This success is at the foundation that drives the investment in a robust pipeline of transformative medicine and PTC's mission to provide access to best-in-class treatments for patients who have unmet clinical needs. MDUK is hosting these seminars because of now we're unable to bring people together for face-to-face meetings through our information days, our family fun days, our national conferences and our muscle groups. However, our helpline remains available to anyone affected by muscle wasting conditions, and please do contact us if you have any questions or you're in need of support. We can help you with information and either support you directly or point you to places where you can get support. The number and email address should be on your screen now, as you can see it right there. So do feel free to call us on 0800 652 6352 or email us at info@musculardystrophyuk.org. I'd really like to take this opportunity to thank everyone who supported our work through volunteering their time or by making a donation, particularly during this slightly unusual time in which we find ourselves. We're hugely indebted to everyone who's helped ensure that we can continue delivering activity like today's session. There's a vast array of ways in which you can support MDUK, so please do contact us if you'd like to explore or visit our website to make a donation or find out more. Just a note to those of you who are viewing live, you can ask questions or make comments. If you hover over the screen or towards the bottom of the screen, you should see something called the Q&A, question and answer function pop up. Do feel free to put questions or comments into that box and we'll try and address those throughout the session this evening. If we don't get an opportunity to address them today, we'll make sure that we put the questions and answers onto our website in due course. Just a reminder to everyone that we're recording this session, which will be available on the YouTube channel at a later date. So, without further ado, I'd like to welcome our amazing panel who've given up their evening to join us. And I'm delighted to introduce them all now. Before opening up into a discussion with you and to answer some of your questions. First of all, I'd like to introduce Ed McIntosh, who's representing the Specialised Healthcare Alliance. Ed is a director at the Policy and Communications Consultancy Incisive Health, where he leads their work with the Specialised Healthcare Alliance, which is a coalition of over 100 charities, which includes Muscular Dystrophy UK, which campaigns for improvement in care and treatment for people with rare and complex conditions. Joining Ed tonight is Professor Ros Quinlivan, who's a consultant in neuromuscular disorders at the National Hospital for Neurology and Neurosurgery in London. She trained as a paediatric neuromuscular paediatric neuromuscular disease and was the first clinical neuromuscular fellow at Guy's Hospital, funded then by what was Muscular Dystrophy Campaign before we became MDUK. At Queen Square in London, she developed and is the clinical lead for the neuromuscular complex, gosh, that's hard to say, complex care centre, and she chairs the London and South East Coast Strategic Neuromuscular Network and is chair of the British Myology Society. She's also a member of MDUK's Service Development Committee. Joining Ros and Ed is Dr. Anne-Marie Childs, who's consultant paediatric neurologist at Leeds Teaching Hospitals NHS Trust. Dr. Childs leads the neuromuscular service there, where she's recognised as which is recognised as an MDUK Centre of Excellence. She's a principal investigator for several clinical trials and works with clinicians across the UK to ensure equal access to research studies and novel therapies for children and young people with neuromuscular conditions, irrespective of social status or location. Joining them is Nick Emery, who's a neuromuscular clinical specialist physiotherapist at the Robert Jones and Agnes Hunt Orthopaedic Hospital in Oswestry. Nick qualified as a physiotherapist in 2005 after being a firefighter in London for 18 years. And he's spent his entire physiotherapy career in neuromuscular disease, and his current role in Oswestry, he works as part of a multidisciplinary team with 2 neuromuscular consultants, 2 physiotherapists, a clinical nurse specialist, a care advisor, and a clinical psychologist caring for both adults and paediatric patients. He runs independent physio clinics, providing care and advice for people with musculoskeletal pain in their neuromuscular disorders, and provides exercise advice. And he's involved in both pharmaceutical and clinical research projects. Joining them is Sue Manning, neuromuscular specialist care advisor from Leeds Teacher Training at Teaching Hospitals NHS Trust. She was instrumental in the early development of the paediatric neuromuscular service and now works as a specialist care advisor in a dedicated multidisciplinary service. Her current role entails offering advice and support to families affected by neuromuscular conditions from the time of diagnosis through all transitions and through to adult services. This also includes liaison with other professionals in health, education and social care. And Sue is also a member of the MDUK Services Development Committee. And I'm delighted to say we're also joined by MDUK's Head of Information Advocacy and Support, Neera Naik. So, we've heard more than enough from me. Let's speak to the panel and hear from them. And Ed, I'd like to begin with you. I mean, we're going to be focusing this evening on accessing neuromuscular services, but could you help us place that in the context of the NHS as a whole and the phased approach that's been taken into sort of the resumption of services following this sort of strange period of COVID-19?
Absolutely, yeah. So, yeah, I'm definitely here to try and provide the big picture, and will absolutely defer to the expert colleagues on the panel with respect to the specifics for neuromuscular and neurology services. But the big picture is a challenging one, and I think that's, you know, a fairly obvious thing to say. But I think it is important to recognise that the NHS is facing pretty much a unprecedented set of challenges. Before the pandemic, the NHS was already sort of under considerable pressure. Waiting times were heading in the wrong direction, and demographic and other pressures were resulting in the NHS sort of feeling like it had to do things differently. So at a national level, it had been trying to drive change with things like digitization, reforming patient pathways to try and change the ways in which the service interacted with patients. And what COVID has done is both massively disrupted care and made things very, very, very difficult for a lot of individual patients who've had their care either rescheduled, delayed, or other ways disrupted. But it's also acted in some ways as an enabler of change and has forced the NHS to change some of the ways in which it's gone about things, whether that's remote consultations, other changes to patient pathways which have had to be implemented. So it's certainly been both a huge problem, but then potentially there are also some innovative approaches that have been implemented, which the NHS is now going to be looking at whether those can be taken forward and preserved moving forward. So in the immediate term, what the NHS is trying to do is recover some of that service capacity, because the response to the pandemic was initially to pause a lot of service provision, make sure that there was sufficient capacity for the COVID patients who are coming into hospital increasingly, and particularly the requirements around specialist critical care and having that capacity. Then we've moved over the summer into a period where the NHS is now telling services that they need to restart and to really try and get back to the levels of capacity that they had before the pandemic. And there've been targets for 100% of the amount of appointments which they would have been doing last year by September, October. Now, I think that is a big ask, and it shouldn't be underestimated how challenging that is actually to deliver on the ground. And certainly the response from organisations which represent NHS bodies like NHS Confederation have highlighted that actually workforce funding, some of the big systemic issues are going to stop that from being delivered. But what services are also being asked to do is think about some of those different things that they've been doing over the COVID period, and are there any beneficial changes which they might be able to lock in and say, okay, we've gone to remote consultations for patients who would have been coming in for a routine follow-up appointment at 6 or 12 months, but instead we're going to do that virtually. Those sort of changes, what can they take forward after the pandemic and look to more to the future. But I think there are also, it's important to say, there are a lot of uncertainties here around how well the NHS is going to be able to come out of this. There are things which are in their control, but there are also a lot of things which are outside their control, like government funding, the impact of things, bigger systemic issues like Brexit, the second wave, how damaging that is. So the NHS is being given a really, really challenging ask at the moment. So I think this winter period is going to be very, very difficult to get through, but it is going to be trying to ask services to do things differently and implement some changes from sort of April next year is really when the NHS is going to be taking a bit of a breath, hopefully, after a challenging winter. So that might be the period at which we do see some bigger systemic changes to the way that services are organised and how they interact with patients.
Fantastic, thank you, that's really helpful. Ros, turning to your service, in particular, obviously you look after adult patients. How have you adapted to the sort of situation at the moment with COVID-19, and particular challenges you think have been faced by the adult neuromuscular services? And I suppose sort of building on things that Ed was talking about, do you think that there are some of the things that you have implemented over the last 6-7 months that you would hope to be able to continue in whatever the new world and new normal looks like?
Yes, of course. As Ed said, it's been a very challenging time. At the start of COVID, everything shut down. We lost, most of our service. So we've had to actually rebuild it. I think also patients themselves are very anxious about coming to hospitals. So it's not just the hospital that's got the problem. I think patients themselves, quite rightly, are anxious about traveling long distances and waiting and meeting other people in clinic. So we have made changes to our service. And I think, as Ed was saying, some of these, I think, going forward will be really positive for patients. So we have instigated, virtually all of our appointments are now are done remotely by telephone or video, although I have to say video still has a few glitches, so it does tend to crash every now and again, but it does work really well. And all of our physiotherapy appointments are done by video now. We're changing the way we assess patients, and we can get quite a lot of information via video. Because of COVID, we also really struggle now to measure people's breathing function, because this is what we call an aerosol generating procedure. So we're having to change how we manage patients. So our respiratory physicians are now giving people their own spirometer to take home, or we're bringing people in for more for sleep studies who we might not have perhaps brought in before. So in terms of how our service is working, what we're tending to do is our patients are quite vulnerable. So virtually all of our outpatients are remote, but we have maintained our inpatient assessment service. And we've made this a very safe, COVID-free area. So we've moved from our normal ward. We have more isolation space. It's only a very small space. We have 50% of our normal capacity. All of our patients have to have a COVID swab before they come in and are screened for infection. And many of our patients want to bring in a parent or a carer with them. And so we get them swabbed as well. And once they're in the ward and in that room, they're not allowed to leave until they've had everything done. But it does mean we can still get their echo done, their sleep study done, they can see a gastroenterologist, they can see a physio. So we can get all of those assessments. And I think going forward, we had been kind of working on this model before, but with more frequent outpatient appointments, but actually many of our outpatient appointments could actually be converted to remote appointments, with our new patients coming for face-to-face, and then patients coming in for a one-stop shop where they get everything done at the same time. So I think that could be a real bonus for people going forward, especially when they have a long way to travel. And it's difficult when they get here, you know, parking is difficult. There are all sorts of other challenges that our patients experience. So I think going forward, I think we're hoping that the software will improve and that we'll have fewer glitches in the video consultations as we go forward. But I have to say, unofficially, I've been using WhatsApp and anything, you know, phone videos, anything when it doesn't work, and it works really well. And I've even had, you know, video consultation with people who can't speak, where they can nod and get someone else to speak for them. And actually the other challenge as well is for people who have sensory impairments. So again, telephone clinics don't work so well for that population. So for those patients, we're trying video, but also email's been working. We've had a lot more email contact with patients. And I think going forward, we'll probably have a mixture of face-to-face and remote appointments. So that's kind of where we are and where things are likely to go in the future at our end.
Fantastic. Thank you, Ros. I saw a lot of agreement and shared sort of frustrations, I believe, from Anne-Marie and from Sue when you were saying about the video, and from Nick also, you know, the video issues. But it's good to see that you're able to find workarounds. But and Anne-Marie, actually looking to you, and the sort of similar question really, I suppose, about how you've adapted the service for children patients, paediatric patients, and their families during this time.
I mean, I think very similar to Ros's experience. You know, everything stopped for a period, and gradually some of our services have come back on stream. I think that it's been really difficult for families to work out how to approach things, particularly when we came to the end of the first shielding process, and when we began to realise the really negative impact of lockdown in many children, their removal from education, and also the restriction in their activity, which I think has had a negative impact on their overall conditioning and certainly maintaining a joint range. But I think that what's really been difficult is that has fallen more severely on certain groups than others. So, you know, families who are fortunate enough to live in a more rural setting and who've got more space have been able to maintain some kind of activity. Families who've got good Wi-Fi, who've got parents who are at home and have got the capacity to do homeschooling. But there are many families where that's not the case. And we've asked these families to cope with children who might have really quite significant behavioural difficulties and cognitive impairments. So teaching and managing them is a challenge for somebody who's trained to do it. And we're asking parents to cope with that as well as do all their other activities. And I think that some people have really borne the brunt of that. I think understandably at the beginning, there was great fear about the impact of COVID itself on children. And I think now we've learned that children thankfully don't seem to have be particularly vulnerable to severe infection. They may get the infection, but it doesn't tend to cause significant problems. But there's been so many mixed messages, it's really difficult for families to have confidence now in going out to school. And because of the pressures on school and teachers and educating young people in these large bubbles, there's so much inconsistency. We find that we're talking to families and they've been sent home, or year 9's gone from that school, and it's very, very variable. And plus we're in a community where some of our families are living in tier 2, some in tier 3, some not sure where they're living, and it's really very difficult to navigate the system. So some kind of clarity is really important. I think that, as Ros said, there have been benefits from the drive to look at different strategies, and we could have spent 2 years trying to set up a Teams meeting or something in the past, and that's all now available. And I think that it has been really helpful for multidisciplinary working across the region in liaising with other clinical teams or therapists who are looking after children in a much more kind of effective way. I think our experience with telephone and video clinics is similar to Ros's. I think there are some people for whom that is definitely the best approach, and for whom that should and will probably continue in the future. But there are challenges to that. Again, some of that's around the kind of hardware. I completely agree with Ros about the software. Unfortunately, the NHS supported software does seem to be the most unreliable. And quite frequently we are saying to families, would you give us permission to use a different platform? And at the same time, the sound and video quality are significantly better. So there's definitely work to be done there. But I think that I would say that there are situations where it's really hard not to do things face to face. So breaking new diagnoses, actually looking at what the best strategy for management is, delivering therapies, that really needs to be done on a face-to-face basis, and you lose a lot, I think, with just using pure video. I think, as Ros says, the therapists have worked really hard to develop SOPs for looking at some of the functional assessments that we're using in DMD and SMA and other models, and that has been really nice. And there is value added, I think, in seeing how children, families, adults are coping in their own settings, because that's what matters after all. But it isn't quite the same as being able to see somebody and think about how best to help them. It's really hard to get equipment. It's really hard to get local services. So people have gone months without appropriately fitting splints or cafes, and in that time things are lost that we are going to struggle to get back. So I think we do need to find a way, as Ros says, of having a safe way of seeing the patients that we need to see in the light of COVID. The other thing I think that has been important for children is that obviously the acute pressures on services have really fallen predominantly in adults, but in centres like ours, where we sit within a large teaching hospital, what happens is that children's services have been reduced in order to support the adult services, and that means that our bed base is cut, our intensive care base is cut, and that means our ability to support people who've got other problems and the normal flu and virus induced deteriorations is potentially compromised. So it's really important that we do our best to try and get as much active management going around chest physio, around making sure we're optimizing any additional strategies that families should be able to access to try and keep kids at home and not require that escalation to a service that might mean they've got to be transported to a unit far away. So I think there have been some good things, but I think overall it's been more of a challenge than a bonus.
Yeah, thank you, Emery. That's really helpful. And thinking about some of those inequalities, I suppose, of people having the access to the hardware themselves and the bandwidth as well at home to be able to be involved in having a non face-to-face meeting is also an important thing to kind of bear in mind, I guess. Nick, thinking about physiotherapy, I would have thought in my somewhat naive world, thinking physiotherapy is by definition quite a hands-on kind of activity and service. So I imagine that the last few months have been quite difficult and challenging for your service, and how have you managed to adapt to support people for physiotherapy, and are there any things that, however, you know, to echo things that Ros and Anne-Marie have said, that will actually be a positive, if you like, that you might be able to take forward going forward in the future?
Well, we started using Attend Anywhere with video consultation quite early on, and that's proved very beneficial. As Ros and Anne-Marie said, the video quality and the sound quality can be poor, but overall we managed to get the physiotherapy message across. It was very difficult to assess people in terms of, especially if they had pain or you know, assessing range of movement, strength, etc. But on the whole, it proved quite positive that we were able to send out appropriate exercises. We had positive feedback. An audit that was done showed that most people were satisfied with the service over the video, and we would follow up afterwards by getting in contact and saying whether the exercise is useful. If not, we can modify them. Going forward from that, yeah, you're right, physio is all hands-on, and that was a challenge, and from that point of view, doing the video consultations required a lot more concentration. We really had to listen hard on what people were saying, because it's very difficult to get that interaction. But going forward, we are opening up to seeing patients. We're seeing probably 50%. So we're doing a patient and then a video consultation, a patient and then a video consultation, which is very good. We're also making sure that we're doing our echocardiograms on the ones we can see. And that's been a bonus, because it's a one-stop shop. So they come along, they get the echo, they see the consultant, they see the physio, so everyone comes along. And we are doing, as Ros said, in terms of spirometry testing, breathing, we're going to get some spirometers, give the spirometers out to the patients who are on the decline, but we would go, well, okay, then we're going to monitor your respiratory function more regularly, but they're going to take them home, do it once a month. It's Bluetoothed, so it goes to their phone, and then they just email the results in, and then we can assess them. So we can assess them every month. We get real-time data, which is probably better than when we see them in clinic once every 6 months or a year. So in that respect, that's a bonus. From my physio-led clinics, I would prefer to see all my patients face-to-face, but some don't want to, and I think that's that fear of coming to hospital. We have the advantage, we're not an acute trust, so we don't, as one of the surgeons said, we don't have sick people in our hospital. People choose to come to our hospital to have elective surgery, or they want to come there. But I think that going forward, there will be a definite demand for those video consultations, and whether it will be a video consultation 1 year and then a face-to-face the next, or whether they will do 9 months and 9 months. It does open up opportunities, and I think that's the important thing. However, we don't know how this COVID situation is going to play out. It's getting worse. Is it going to mean that we are going to have to then change the practice and go back to more video consultations? I hope not, because the knock-on effect has been huge, especially for those patients who require that surgery, that foot surgery. And you know, with the CMT, what I didn't say is that you missed that window of opportunity with a foot, and you've pretty much blown it. So there is positives, but there are also a lot of negatives.
Yeah. Yeah, no, thank you. That, yeah, interesting points you've brought up, and I'll come back to a couple of them in a little while. But just before we do that, Sue, I'm just sort of thinking to you the sort of service that you provide as a care advisor. How has your role adapted to the COVID-19 and the issues that people who've got muscle wasting conditions sort of been affected? And again, I suppose, are there things that you've gained from this that are positives as well as the kind of challenges?
Mm. Well, like a lot of people that have already spoken, you know, we soon had to adapt to a different way of working, because a lot of my work was face-to-face. I did do a lot of telephone support as well, but face-to-face mainly with families, and of course that changed very quickly. So yes, using the new technologies and learning things that I never thought I would, and having colleagues that were a bit more tech savvy than me have taught me things. So that has been positive. We've been able to use technology to access families and support them. The beginning of the pandemic, there was an awful lot of anxiety and worry amongst families and within the professionals groups as well. So there was a lot of time spent there. It was a lot of emotional support. There was information that we had to obviously get through to families, and of course, as we all know, it was changing very quickly, and that was a big challenge. Going forward now, we are seeing families face-to-face in clinics, which is absolutely marvellous now. It's actually the first time that we had a clinic and we were seeing patients and families face to face, I thought, oh yeah, this is great. This is what I do. I can do my job again now. But we are looking very carefully at those face-to-face consultations, because those numbers have been reduced that can be accommodated in outpatients. So as a team with Anne-Marie and the doctors and the therapists and the nursing staff, we all look clinically to see who should be seen as a priority. We have a therapy clinic, our physiotherapist and myself, and we've started to see patients again and families face to face, and actually, you know, that's been very successful. Everybody that's been contacted has wanted to come back and see us, and so that's been you know, sort of a hands-on assessment could take place, and that's been rewarding as well to be able to do that. But again, looking at clinical priorities and perhaps using other methods of assessing patients and families and accessing them if they didn't actually really need to be face to face. I've had a lot of work with schools over this time, and since our children and young people have been going back to school and college, there's been a lot of support, again, some of that virtually, a lot of virtual meetings now, the educational and health support meetings and reviews, a lot of those are virtual. Some schools are still now asking for training, because that's a part of my role, supporting other professionals. So we're using, again, technology and to offer that. So that's coming into place again. I think the new families that we're seeing and the new diagnoses that Anne-Marie already mentioned, they are as a priority, and we are seeing those face to face. And I am offering home visits again now with all the protection that we need, and with the families feeling happy with that, and supporting some young people again and starting to do that level of work. I think one of the other big challenges has been that liaison with other professional groups and other organisations. So social care, a lot of issues there for families, and follow-up, you know, disabled facilities grant, everything seemed to get stalled and continues to get stalled, getting the equipment in. So that's a frustration. And some services using different platforms than we do in health, which makes it really difficult to communicate. So it would be nice if we could have something that interlinked and that passed all the regulations, so we could all use it and it would all be confidential. So I think for me going forward, I think it will be a combination of using that technology and hoping that it will work more effectively. But I think it's really still important to have that face-to-face support for families, and seeing them in the hospital situation, but also in the community, and offering those visits when it's appropriate in the home setting.
Mm-hmm. Mm-hmm. Super, thank you so much. We've had a couple of questions live, and we've had a couple of questions submitted earlier, and there are some things that you've all said that have sort of triggered some thoughts in my mind. So first of all, I suppose there's a question around, are you aware of whether there have been delays in diagnosis? I mean, we've talked a lot about families who sort of are already known to you? We've talked a lot about that, but, you know, families and patients who we don't yet know or should be coming your way, has that been a problem? I don't know, the Ros and Anne-Marie, maybe you could touch on that.
I mean, I would say the difficulty is we don't know, because we don't know how many people might not be being referred. I think that there has been a great challenge for primary care, seeing patients. So I suspect that some of the normal monitoring that would go on around sort of health surveillance hasn't happened. We haven't had perceived difficulties in getting the certainly single gene tests. That hasn't been a problem. But trying to progress more complex genetic tests has been a challenge, and these have been delayed because obviously the COVID testing is largely a genetic test, and that has taken up a lot of capacity for genetics. And that goes back to the comment Ed says, you know, we don't have systems that had much slack. So, you know, that has been a problem. I mean, generally, if we can say that it is going to have a major impact on a young person, child, infant's management, we may be able to progress things, but definitely there's delays there. I'm definitely aware of delays in other neurological disorders as well, because I think that people haven't been able to seek the support and advice that's the first step of the referral pathway. But I'm sure there are people out there that we don't know about.
And I would add to that as well. I think between March and July, there was literally no genetic testing because of the COVID testing. And so I think if we have another huge second wave, it's quite possible that we will go back to that situation. And as Anne-Marie says, that the genetic laboratories were just doing COVID testing. Also, between March and September, it was very difficult for us to get MRI scans, EMGs, and muscle biopsies for the same reason, because everything shut down. But this is now opened up, and they have a prioritization system. So one of the problems is they can't open up to full capacity because they have to ensure that they are socially distancing everybody that comes in. So capacity is reduced, but they have a triage system of red, amber and green. So the red, you know, anything urgent will get seen straight away, but there may be slightly longer waits for people who are not urgent.
Oh, thank you. That's very helpful. A question from somebody who is transferring from one area to, or has transferred from one area to another, and it will be attending clinic in Newcastle, and they will be sort of doing a kind of one-stop shop, to quote those sort of complex care kind of package. Do you think that they are, I mean, this is a little bit of conjecture, but you may have heard something about whether they're going to have that sort of similar COVID-free environment that you've spoken about, Ros, where, you know, you sort of test people before they come in and anyone that's coming with them, and sort of lock them in a room basically until they can leave.
I'm sure, I mean, I can't speak for Newcastle, but even, I mean, all hospitals are developing separate pathways, which we call blue and green pathways. So even in our outpatients department, we have two separate outpatients. We have a green outpatient department, which is COVID free, as much as those patients are not tested, but these are shielded patients. And we have a blue pathway for non-shielded patients who potentially could have COVID. But actually, every single person who enters our hospital has their temperature taken at the door. And I don't think we're different from any other hospital. You know, as I say, I can't speak for Newcastle, but I'd be very surprised if they hadn't put some measures in place to reduce the risk.
And I certainly think that it's worth contacting them to find that out, and they will be more than happy to talk you through whatever measures that they have in place. So that was a really great question, I think. Also, just sort of touching, and again, and I don't know whether there's anyone on the panel today who will be able to answer this, so we might need to take this offline later, but thinking about things like wheelchair services, and have these been affected, and how can people get appropriately fitted for wheelchairs safely? And maybe Sue, you might be able to start on that.
I can say certainly in our region that wheelchair services have been affected. I mean, we had issues prior to COVID with certain wheelchair services with long waits and times for assessments, and that was difficult prior to COVID. And that has just increased really, because those staff initially were not seeing face-to-face patients and weren't assessing them. Then if you put into the mix that staff that may have had to shield themselves, you know, the effect that the pandemic actually had on staff supplying services. And some staff were redeployed, and I know that therapists were redeployed into different areas. So most definitely waits and have increased, and access to assessments, most definitely that has been a very negative effect in my area, certainly.
I don't know whether anyone, I mean, I don't know whether Nick or Ros, you've heard of anything in your areas respectively, or not necessarily.
Yeah, there's been more delay in certainly getting wheelchairs to patients, and the way that things work in Shropshire and the surrounding areas, I do the referral, and I do the referral form, take all the measurements to specify the condition, specify the type of chair, and then that goes in, and some of the chairs are then just delivered. So some patients are getting the chairs, but when you ask specifically for an assessment, that has been the delay. The other delay that has happened is in the provision of orthosis, especially out of area. Some areas are actually being open to seeing patients for request for orthotic provision, and some aren't. Our hospital is open and they are seeing patients. They're quite happy to see patients. So when it does come out, I try to get them seen through Oswestry, but it's not always possible due to funding. So that's another area that's been quite difficult.
Mm-hmm. Thank you. Yeah, and Ros, I don't know whether you've got anything.
I would just agree with Nick. I think it's hit and miss depending on where you live and the urgency of things. Yeah.
Yeah. Nero, did you want to add anything to that?
Sorry, struggling to unmute myself. In terms of our helpline, yes, that's been a big thing with queries that have come through. I think it's two things: the delay in getting assessments, and even when you have had an assessment, to actually have the fitting done, etc., to have the chair delivered. And we've had an awful lot of inquiries about funding as well. So it's definitely an issue. But across the board, even with any sort of services, we saw that it stopped. And then sort of June, July time, things have picked up.
Okay. So there is a glimmer of hope there, and yeah. Okay. And Ed, I don't know from your perspective if that's sort of, I mean, it's probably quite specific to the population that we look after, but I don't know whether there's anything that you know from your perspective on these kinds of services and the provision.
Yeah, I mean, I think a lot of services are facing very similar challenges ultimately at the moment. I think, you know, they're trying to work in different ways. They're trying to deliver the best care to patients that they can in what are very challenging circumstances. And I think there are a lot of things which are out of their hands. So I think it's about trying to make sure that the sort of the centre, whether that's the leadership of NHS England and others, or the government, are cited on some of the challenges which are existing on the ground, and whether that's, you know, engaging with your MPs or, you know, going and talking to system leaders. I think it's important that, you know, the centre doesn't lose sight of what is actually happening for patients on the ground. I think that's often something which does happen. So I think that's one of the gaps which exist, and which is where sort of the Specialised Healthcare Alliance is one of the things that we try and do, is bring those problems and sort of raise awareness of them at the policymaker level. So that's certainly something we'll continue to be doing on behalf of MDUK and others moving forward.
Fantastic, thank you. And picking up on something that was sort of discussed earlier, how much effective difficulty are the panel experiencing, especially those in sort of inner cities and with ethnic minorities, is there a population that's sort of being missed out at the moment with this sort of move to a more technology-based system? And I suppose also thinking about people having potentially difficulty in getting transport to attend clinic. I don't know, Anne-Marie, would you want to start with that?
I think that follows on from what we were discussing previously, is that I think there are communities that are disadvantaged, particularly at the moment, whether it is about hardware. But one of the really difficult problems that we've encountered, and I guess Ros will have had this too, is that in some of our communities where the families don't have English as a first language, and these often are the areas where there's the greatest social deprivation as well, it's been very difficult to use these other medium, because we cannot patch an interpreter into a video call for some reason. I don't know why. We have to use a telephone language line, which then doesn't really work with a video consultation. It doesn't work very well with families either, and it certainly it makes for a very disjointed, difficult conversation. So I think that is a particular challenge. But I think that, deprivation as a whole has an impact on, again, it's back to that hardware, but it's also your capacity and your parents being around, or your carers being around, and not having to go out and do, and particularly at the moment where there's conflict with, you must go to work if you can, but you can't actually support each other as a community anymore, unless you happen to have one particular bubble. So that it's a really difficult thing. So we've had parents who've declined to bring children in for treatments because we've said they've got to isolate for 2 weeks because they're in a tier 2 or 3 area, and therefore they can't officially come into the hospital according to our guidelines, but they can't get any support for not going to work because there's no resources for that. So I do think we need to raise that with the politicians, and it's a real challenge for some families, and I do think it is falling harder on certain communities than others more.
Yeah, I fully agree, and we are also very aware of this problem that families are facing, whereby yes, go to work, but you've got a quarantine, and yeah, that's very, very challenging, and it hasn't really been properly addressed yet, I don't think. Ros, did you want to add anything?
No, I totally agree with Anne-Marie. Exactly the same issues, actually. Firstly, about non-English speakers, but as I said, also people with sensory impairments as well. I think they're the major difficulty with the new remote clinics. Yeah.
Yeah, and the other thing I'd like to say is that although obviously Oswestry isn't in a metropolis, the social isolation can actually be worse because of the countryside. That people are so isolated that it's even harder to access services. And the internet in cities is supposed to be better. I know it's not always better, but out in the countryside, it can be atrocious, and even phone signals can be really bad. So the problems are just as complex out in the countryside as they are in the cities. Yeah, no, thank you. That's also an important point about, yes, my parents live in a fairly rural area, and sort of, standing on one place and hoping that the signal comes round again when you're trying to get somewhere. Yeah, no, I appreciate that. That can be a challenge. I mean, thinking sort of to the future, and we talked about people coming into clinic again, but you've also mentioned, some of you, about how people rightly at the moment have a lot of anxiety about coming into clinic. How do you think we can work with families and with people to sort of help them to sort of overcome that anxiety, to start to be able to come back to clinic and to sort of other activities that are more how things were before March? I'm not going to say normal, because who knows what that is, but are there things that you're starting to think about, or is it too soon to start to think about that? I don't know who wants to answer that first.
I think this is a really difficult problem. I think it depends very much on where you live. and how much COVID is in your area. I think that, and also whether you're generally an anxious person or a non-anxious person. So I think there are multiple levels that play into this. I think the most important thing is that when people need to be seen because they have a problem or because we anticipate a problem, that they must, that actually maybe COVID might be less dangerous to them than being, you know, having been seen by the cardiologist if they've got a heart problem, or being admitted to start ventilation if they need to. That, you know, it's more dangerous to not do that than to be worried about the COVID.
Mm-hmm. Yeah, I don't know whether anyone else has any thoughts, Sue.
I was just going to add, I agree with what Ros said, and we've had lots of different reactions from families and parents, and I think it is complex and it depends on your own circumstances, your own view of risk, how, you know, what information you've been given. And I think it's been so difficult for families to work out who do I trust, what information is correct, and that's been really difficult. We have tried to communicate with our families and used email and then a lot of actual just telephone calls to each family directly to offer that extra support, especially when we went out of shielding, to reassure parents and the young people themselves. And actually they've been pretty astonishing in the young teenagers that I've been working with just recently. And one young lad said to me this week, he said, you know, I'm not frightened of COVID. I don't want it, but I'm not frightened of it anymore. And it's about, sometimes it is just that personal conversation that you need, but it's having the time and the resources and the correct information to be able to guide families. And it does help when you've had a good relationship with a family and you've known them for a long time.
Yeah, no, I can see that. Thank you. Nick, did you want to add anything? Or
yeah, it's just having those conversations with the patients and the parents, carers, etc., making sure that they understand that you're taking all the precautions you can possibly take, and they can take all the precautions they can possibly take, and the process that happens at the hospital, so that they are screened before they come in, the temperature's taken, the staff are in appropriate PPE, the rooms are all wiped down between patients stay in the room, the clinicians move between the rooms rather than the patients moving between clinicians, so that reduces risk. And also having the psychologist, we're very lucky to, unfortunately, to have a psychologist who then can talk people through that anxiety, trying to reduce their anxiety. Obviously, she can't assess our 1,200, 1,300 patients, but if there's people who are particularly, as Ros said, who need to come along for that cardiac, need to come along for that sleep study, and if they're really anxious, having it is less dangerous than catching the COVID. So you know, having those problems addressed early on, and having that confidence that we are there for them. And as you know, we have a really good relationship with 99% of our patients, and they know us. So that's super important.
That's fantastic. Thank you. And Anne-Marie?
I mean, I think, you know, I echo what everyone else has said. I think that it is really important that there's clarity, though. And I think that one of the really difficult challenges is navigating around the advice and knowing who to trust, if you like. So I think that having a combined message going out from our networks and from organisations like yourself is really important, because I think that families have learnt to trust you and hopefully us as being perhaps in the best position to discuss these things they're worried about with them. And it's when they get mixed messages from the media or from government, dare I say, that it becomes very difficult. So I think that that's important. I think the other thing is really just highlighting what Ros has said, is that I think that we need to have good infrastructures in our own organisation so that we can prioritise those patients, and that takes time. You know, that means that we've got to work together and have good information that allows us to pick out those patients that do need prioritisation. And again, you know, that's down to resources, both the kind of, if you like, having your up-to-date databases, but also having the people who can get together and make those decisions. So it's a kind of different way of working that the trust doesn't necessarily, I think trusts don't necessarily recognise that as something that would be part of if you like, a job plan for somebody, but it should be now.
Mm-hmm. No, that I can see that. Yeah, thank you. Neera, you had a question about shielding.
Yeah, I did. It's something that's come through to the helpline once again quite often. So the government paused shielding in August, but there's still that massive reluctance to do things. And I think people come to us and ask us the questions, should we do this, should we do that? I think the clinical side's a bit easier. We say speak to your consultant. If they have the blue route or a process, then go to your appointment, because they are really important. But we do get a lot of questions about, can I go out, can I do this, can I do that? And I think there's a lack of clarity both from the government, and we have some COVID guidance, but there's only a certain level we can go up to in terms of our advice, so that appears to be quite a big struggle at the moment. And especially as they are saying that if you are in a tier 3 area, that there is potential that you will need to start shielding again. And definitely the concerns with not being able to work, not being able to get benefits, etc., is a massive struggle as well.
Yeah.
Can I just add something? I absolutely agree with Nero, and I think for people who are listening, I think it's really just important to be sensible, because I think shielding, as we now realise, was really damaging for a lot of people psychologically. I think if you can go out somewhere where you're not going to come into contact with many people, it's really good to go out and get some fresh air, you know, rather than staying indoors all the time. So I think I would just say to people, be sensible, you know, read, you know, what's happening in your local area, know what's happening, and then make your own judgments about what you feel is going to be right to you. And also balance. The real risk of COVID is actually not for young people, which most of our patients, but actually old people like me, you know, and my husband, and, you know, actually young patients are, you know, the risk for most of our patients for COVID is going to be very small, actually. Yeah,
Thank you. That's really, really helpful. There is just one other question that we had in advance, which again is a slightly kind of specialist thing, but it's also an important thing. I mean, talking about people wanting to do things and get out there and exercise or you know, experience the world beyond the four walls of their own home. Things like hydro pools and swimming pools and getting access to those. You know, a lot of times they're only sort of open for particular people, or you know, for particular groups of people. Do you have any advice for people who are finding it difficult to access hydrotherapy, hydro pools or swimming pools and things? I don't know whether Sue, you might have come across this from your perspective.
I know it has been an issue that obviously a lot of pools have been closed and they've been limited when there's been hydrotherapy again to face, and what is you know, enabled and allowed within the hospital setting. But as you know, as one person said to me, well, you know, the chlorine in the water is going to kill everything off, and so from a COVID risk, actually being in the water is you know, the benefit of being in, we all agree, is going to outweigh any COVID risk. But I think it's just the accessibility of them, and the very fact that so many local authorities have, and private gyms, you know, that were closed and have had worries about then reopening them, and it just does vary from region to region. And I haven't got an answer really. I think it's about just looking what your resources are in your locality, and trying to fit what you can around that. Yeah, I haven't got a a catch-all answer to it all, because it's very variable. And again, with the different tier systems now, and we know some gyms have been closed, now they're opening again, so it's moving around all the time.
Yeah, no, thank you for that. I'm very mindful of time, and I'm very grateful for all of you for your time. I just wonder whether any of you have any, so I'll go round to all of you, but if you've got any sort of final pearls of wisdom or things that you would like to share with us just before we finish for the evening. So if I start with you, Nick, just because of the way I go around my screen.
I think that people need to attend for the important hospital appointments. I think that's critical. I think there are things people can do to remain active, even if they're able to go out for a little brisk walk, as long as even if they've got a mask on and they're happy to wear a mask, or if not, just get some exercise, get some fresh air. There's things they can do at home. You can buy relatively cheaply some floor pedals, which you can use for your lower limbs or your upper limbs. So you can do a little bit of exercise at home. Accessing gyms, etc., is going to be very difficult. And to be honest, I'd wait. I'd rather people are on the side of caution in that respect. Other than that, contact your centres if you need assistance or help. And that's it, really. Brilliant,
thank you. Sue.
Yeah, I would just say we are open. Services are running differently, but please seek help from your centre and the people that you're working with, and don't be afraid to do that. And again, just a bit about stepping out the door, and for all our emotional and psychological support, it's important that we start to engage in activities, and you assess your own level of risk, and be careful but be sensible about it, and hopefully we will all get through the winter.
Yes, yeah, thank you. Nero, have you got anything you wanted to add?
No, not anything specific, but just to say our helpline is open. We are here to help. So call us with any questions. And if we don't know the answers, we'll find somebody who does.
Brilliant, thank you. Before I go to Ed, Anne-Marie and Ros, late breaking questions. Somebody who had overnight care for 3 nights a week, their carer retired, as I was skim reading this, during lockdown, and I don't think that they've necessarily found anyone else. Sorry, I'm now skim reading and trying to speak at the same time, which clearly is not something I'm very good at. So yes, they haven't had any overnight care since March, and is there anything that people have heard of? Maybe this is something that we could pick up, Nero, and we've got the contact details, I imagine, of that individual, so we can take it. But I don't know whether anyone on the panel has had any knowledge of anything or any suggestions. Fine, we'll pick that one up latterly. So thank you for asking that question. We can certainly pick up with you. So sorry, back to my list of just checking in with everyone. So Ed, is there anything that you wanted to just sort of finally pitch in with?
I mean, there's nothing specific to add. I mean, I think obviously, as I started off by, a bit of doom and gloom that we've got massive challenges, but I think it's really heartening to hear from the clinical colleagues on the line about how hard they've been working to try and make services deliver for patients, and I think that's really testament to the really hard work which goes on. So I think from that perspective, I think that the services hopefully will continue to do that, and then we'll come out the other side of this, and there will be improvements that will make a difference for patients.
Thank you, super. And Anne-Marie?
I mean, I echo really what's been said. I think that I think patients should feel reassured that we are working closely together to try and work out the best way of supporting their needs, and we're learning from each other, and we're working to make sure that the advice is consistent and clear. It's really important that you don't hold back if you think you need to come to hospital or if you're ill. I feel quite confident that the systems are in place to protect young people. I mean, we may look weird and scary, but I think that's part of the system. But I think that it's going to be probably hard again over the winter. And so it's really important that you don't stay home when you're not feeling well, and completely agree with Ros and Sue and Nick. Use your common sense, get out, do the things that are important, that make life worth living in a sensible and safe way.
Brilliant, thank you. And finally, Ros, is there anything you'd like to add?
I'd just like to echo everything everyone has said. What I would say is this is a constantly changing situation. As we've seen, we were virtually COVID free in the summer, and now it's creeping up again. So constantly reassess your own risk for going out and your own risk for family members. But we take risk very seriously in the hospital. We do a risk assessment for everybody, as Anne-Maria says, and we would not bring you into hospital unless we thought it was going to be safe for you. So rest assured, we work really hard to maintain your safety and your good health.
Brilliant, fantastic. Thank you so much. So that's us. That's the end of our session, and thank you so much to everyone for participating, and everyone for being on the panel. Really appreciate your input. It's been absolutely fascinating and really interesting. So I'd just like to also thank our sponsors, PTC Therapeutics, and just to remind everyone that the video of this session will be available either certainly in the next few days. But just leaves really for me just to say thank you to all of our panelists for giving up your evening, and thank you, and have the nice rest of the evening, and we'll, I'm sure, be speaking again soon at some point. Thanks everyone.
Thank you.
Bye.
Thank you. Bye-bye. Bye.